Hello, I'm Dr Annalene Weston, Dento-legal consultant at Dental Protection. Welcome to RiskMatters, our latest series of podcasts created specifically for dental practitioners in Australia. As the name suggests, RiskMatters is all about managing risk. In this podcast series, we'll be taking your feedback and queries and putting them to leading industry experts, getting them to answer the difficult questions about managing risk and working safely. It's all about what to do when managing risk matters most. In this edition, I was lucky enough to get some time with Emeritus Professor Laurie Walsh regarding the recent changes to the infection control guidance, namely the replacement of the standard 4815 with AS 5369, the reprocessing of reusable medical devices and other devices in health and non-health related facilities. And of course, the subsequent updating of the ADA infection control guidance to match. Laurie's a specialist in special needs dentistry who's based in Brisbane, where he served for 37 years on the academic staff of the University of Queensland School of Dentistry, including 21 years as Professor of Dental Science and 10 years as the head of school. Since retiring in December 2020, Laurie has remained active in hands-on bench research work, as well as in supervising over 15 research students. Laurie's been teaching microbiology and infection control at a postgraduate level for over 20 years and has served on the ADA Infection Control Committee for 23 years, including 7 years as its chair. And Laurie's published extensively in microbiology and infection control and represents dentistry over several Standards Australia committees. So let's have a listen now to what Laurie has to say and how he has responded to the questions that you've asked us to put to him. Thank you so much for taking the time to join us today, Laurie.
It's a pleasure, Annalene.
So as we discussed, I've got a couple of questions from our members to put to you, things that they really want to know, but I really haven't had the opportunity to ask anyone else. So I'm grateful that you're willing to do this for us. So these questions have flown on from the change in the infection control guidance. So I suppose the first question to ask, Laurie, is why did the guidance change?
So over the period of time, in every country, there's always a process for updating information to take into account new science and also changes in international standards, because all countries try to harmonise internationally. So over the last 10 years, there's been quite a lot of changes in the international standards that relate to the reprocessing of instruments. And at the same time, in Australia, we look at standards that become aged. So when they get to 10 years old, there's always a question asked about, does this standard need updating? Is it okay as it is? Or does it need to be brought back to the drawing board and done again? So in the case of reprocessing, the last standard was the 4187 standard from 2014. So basically it was ripe for a relook. And of course, the opportunity was always there to consolidate with the previous 4815, which was getting on to 18 years old. So it was really just a question of timing. And when standards get updated, there's technical changes and there's also new information and new philosophies. And also sometimes there's a change in thinking. And there is an important change here, which is that now, instead of being very prescriptive, it's now much more based on assessing risk at the local facility level. So that's a really important and very useful change. So that's sort of the background for why the change has happened.
Now, that's really helpful. Thank you. And I remember you and I have discussed this before, and you were saying to me that some places have got more changes to make than others. So there's like a roadmap. That's correct, isn't it?
That's right. In fact, the Australian Commission on Safety and Quality in Healthcare has actually published a little mini summary of the transition journey. So practices that were operating under 4815, which is most small office dental practices, they have a few more items to work through in terms of meeting the requirements for reaccreditation in the next round, whereas those under 4187 have already come some distance down the road, so a bit closer to target, if you like. So they have a slightly different and easier transition, because at the end of the day, it's all about people being on a journey. It's not about reaching absolute perfection. It's all based on continuous improvement.
That's really helpful. Thank you. And it's helpful, I think, that they're considering the global standardization. I know as someone who came from overseas, when I first came to Australia, everything looked different, even though you're in the surgery. So technically it's the same, but the materials were different. They were packaged differently. The processes felt different. They probably weren't, but I looked around and there was literally nothing I recognized. And that's quite confronting, I think, when you come in, because you're like, is this safe? So I think some standardization will be super helpful.
I think, I've been in dentistry in 32 countries around the world, and
Gosh.
many of them are very similar to Australia, and there's only really trivial changes. And other ones, it's a completely different world. For example, in some parts of Europe, it's not normal to have a dental assistant, and that changes everything because we just get so used to working with four-handed dentistry. So sometimes we think our own 8 or 12 square meters is the world, but suddenly you realize the world can be very different outside that little room. Yeah.
That's a really good observation, and you're quite correct too. So one of the questions we've been asked, and I think we'd all be curious about this, Laurie, is has COVID had a big impact on the guidance?
Not so much in the reprocessing standards or in the ADA 5th edition, because when we did the 4th edition, which was around the time of COVID, we also did the managing COVID assessment pathway. So we did a couple of specific documents for COVID. So in a way, that was sort of done and dusted. But what has happened, though, and this is something that people might have seen on the news recently, is that because of the review of the government's response to COVID, there's now been a move to set up an Australian Centre for Diseases Control. So what that means is in the future, things like the NHMRC guidelines, which are currently badged with the NHMRC and the Commission on the front, will probably now come out through the Australian CDC, because it's really like a coordinating agency for infection control, and not just pandemic stuff, but everyday stuff. So that's one of the big changes that will happen. But in a way, that's a type of upstream change that probably many people in practice won't really take a lot of attention to, but it is something that is important, because what happens when you consolidate things is you get less variation and the advice becomes a lot more consistent and uniform. And that's the type of process that when we made the ADA guidelines, we went to the Commission on Safety and Quality, we went to the Australian College on Infection Prevention and Control to make sure that there was harmonisation with what people were saying. So it was one uniform type of message.
Yeah, that's really helpful, because I think particularly it's something like infection control. You need one voice, you need one song sheet. Otherwise, it's so easy, isn't it? It's so easy to get things wrong. I've read since the change to the infection control guidance, which of course was earlier in 2024, depending on when people are listening to this. And then the ADA guidance, of course, updated to enable us to enact the changes, because it is our working manual. I've seen a lot of updates online. I've been to 2 ADA webinars, I've read some articles, and I'm coming to an in-person update with you, actually.
Fantastic.
Yeah, in a few short days. You know, I attend infection control a lot. That's you and I often cross paths, and I ask you lots of questions. We often get asked, people say, how often should I go to infection control? So let's start off. How often do you think we have to go?
I'm not sure it's a question about attending something in person. It might be, an online webinar or something like that people, find pretty convenient as well. But if you look at the dental board's frequently asked questions about infection control that they updated in February of 2024, they talk about people keeping their knowledge current and up to date. And in Queensland, we have the Infection Control Management Plan, which is under the Public Health Act 2005, and that requires periodic updating. And I guess if you overlap those two circles of activity, then once a year seems reasonably intelligent, because that will pick up new standards and guidelines and advice which has come out. And I guess it's a chance to say, are we up to date with the latest things? In the past, some dental boards in the days before AHPRA used to mandate infection control. The Dental Practice Board of Victoria was well known for that, for example. And then when we went to AHPRA, the board moved to a position which was, you're big people, you need to figure this stuff out for yourself and keep updated on a whole range of stuff that might change. And infection control is just one of those areas. But the boards current FAQ and guidance does say that people, should be doing it on a timely manner, but they not being very prescriptive about that. And that's good because it will differ for some environments from others. So
yeah, and times of different people. I think that's how long you have to. I think should and could. I think after the guidance has changed is a really good time to have a look, don't you?
Oh, absolutely. Because I think, what you're trying to do is really a gap analysis and say, oh, here's something new, something that we can address and sort through, or, oh, this is something we already know. We're okay. We're on top of this. So continuous quality improvement always comes from a platform of going, we're fine on this. We can do better on that. And here's some long-term stuff we need to start thinking about now. So it's really those three legs of the chair, what it's all about.
Yeah, definitely. So one thing that I'm struggling to get my head around, I'll be quite honest about this, despite the infection control CPD I've done since the change in guidance, and this is a question that we're getting asked a lot, Laurie, is the current position regarding air removal and steam penetration tests. So are you happy to talk about that? Because I know it's a bit of a movable feast at the moment, isn't it? So tell me all about it.
The reason the feast is moving is that there were some alternative explanations that were brought to the table 8.2 and the accompanying section of text in the standard after the standard was published. So the standard went through 2 rounds of public consultation. Many hundreds of comments came back to the drafting committee, and we spent literally days and days and days working through all those comments. And no one ever commented about this. And then the standard comes out and someone says, oh, by the way. So when the committee has gone back and looked at that, the decision's been made that there should actually be an amendment done to that little piece of text and that table to make it absolutely crystal clear for people what the situation is. And the ADA drive this process by pointing out to standards, this is what's in the text. Here are some of the different interpretations, and then these are the implications for our ADA members in terms of like sourcing product that meets those requirements, because it's become a little bit tricky in that space. So ADA has really driven this process, and now standards are responding to effectively what the ADA has said our members need clarity around. So it's a really good example of advocacy happening here. So when you amend a standard, not only does the technical committee and various subgroups have to work on that to make sure it's exactly right and then vote on it, then that goes to public consultation, just like the original standard did. So that amended bit, when it goes to public consultation, it'll be out there for 3 months, and then people will have the chance to say, we love it, we hate it, we want to change this word, etc. And then every one of those public comments then has to be addressed in committee and discussed and argued and debated, often at some length. And then the amendment can be finalised. And then when it is, that amendment will be available for free online. People won't need to pay to see it. So the outcome is going to be very good. But for those wheels to turn, the process of an amendment is about a 6 months process. But what it does is it just eliminates all confusion, because there's now a really strong focus on making sure that everything is exactly right. And not only that, it's road tested in that 3-month public consultation. So that that's it. It's done, dusted, sealed, end of story. So I know it seems like the wheels can turn a bit slowly, but to get it exactly right, this is what's happening at the moment. So that amendment will go through public consultation in 2025, and certainly by mid 2025 at the latest, I'm pretty sure that the dust will all have settled and everyone will be happy.
That will be amazing. And where do people find consultations if they're interested?
So when you go to the Standards Australia website, one of the buttons which you'll see is, these are the current consultations. Now, people do need to form a login just so they can actually have an identity that can be assigned to their comments and things, but it doesn't cost any money. And you'll actually notice at any one time, there's about anywhere between 20 and 30 standards are up for comment or amendment. Everything from, latex rubber or tires or electrical safety or, concrete testing, all the things that standards are about. So the dental piece is just one element of an enormous amount of different standardization work which is happening. So people might need to scroll through to find, here's the 5369 amendment, and then they can make comments on just what the amendment says. And it's not so much to say, we love it, it's fantastic. It's more if people have particular comment, there is a template they download which says which line, which words, what don't you like, what do you suggest should be changed, what's your reason? So that informs the committee about what's in your headspace so it can be argued about appropriately.
Oh, that's fantastic. Thank you. And I think it's another timely reminder that we're not the only thing in the world. The fact there are other standards outside of ours. It's not just us.
Absolutely. I mean, just to give you a sense of how long it can take, the standard which actually at the international level sits underneath this particular amendment is known as 11140 Part 6. The committee that worked on that at the international level took 12 years to put that standard together. So it's quite a complex piece of work, and that came out in November 2022. And that's what actually forms the definitions that are relevant to small office practice steam sterilizers. So it's all about timing and making sure that this is done once and it's done right. It's the old measure twice, cut once principle working again.
Yeah, absolutely. So you said small office. By small office, do you mean as in a dental practice compared to a hospital, or are they looking at the size of the sterilizer when they say that?
No, this is about the size of the sterilizer. So the different standards around the size of sterilizers like EN 13060 or EN 285 basically have capacity chamber sizes in litres. So if you're 60 litres and above, then you're a big sterilizer and you operate under EN 285. And there are particular tests and issues around big steam sterilizers, like the big ones in hospitals. They don't tend to generate their steam locally. It actually comes from the energy plant centrally. So there's a whole range of different problems around steam in a big steam sterilizer, plus having to jacket it and heat it up. Whereas in a small steam sterilizer, you switch it on, it warms up, and then you get into it. So that's why those sit under a different group of standards. And it's also why the testing devices are a bit different too.
Now, that's really helpful. And but Laurie actually gave me a visual for this before. So a small steam sterilizer is what we generally have in dental practices because it's one that sits on the side. Because when Laurie talks in things like literage, it's all above my head. And a big steam sterilizer is like a fridge freezer or bigger, like the size of my wine fridge, like that kind of. It sits on the floor.
Yeah, that's a good analogy. I guess the smallest steam sterilizers would be things like Statums or NBios, where the chamber's only 2 litres, and they're like a little cassette sterilizer. They're about the size of a briefcase. So that's about probably the smallest physical size of a steam sterilizer. And then probably the largest ones in a regular dental practice would be probably a 22 litre or maybe a 24. Generally, once you go to a really large clinic, like, for example, a big dental hospital or a dental school, you've normally got, 200 or 300 litre sterilizers and often more of them. I know at the Old Health Centre we have 8 times 300 litres. So 2,400 litres of stereo all happening at the same time.
Yeah, all going at the same time. It's crazy, isn't it? I'm only in practice, we'll call it sporadically, 2 or 3 times a month. And so one of the things that I do reasonably regularly when I'm in practice is I hop into the steri room, I have a sniff around, and I ask the staff what tests have been run, and I ask to see the logbook and all those things. And it has been suggested to me in the past that I'm quite mean for that, but I do think it's important because as a registrant, of course, I'm equally as responsible for anything that happens regarding infection control breaches, whether I'm on the premises or not. So it's important to me to know what's been going on. So for those practitioners who are in practice every day, how often do you think they should be just popping in and having a look at their steri room and getting a feel for what's going on?
Hopefully in most practices you'd be having some type of huddle or planning meeting, once a week to say, these are the big things coming up this week. And it's always good to have a standing item in that is that have we had any incidents or outlier events that we need to talk about? And that is a great way of people to bring up if a particular sterilizer has a certain personality and it's beginning to, go offline, this is a chance to bring that up in terms of we haven't reached a problem yet, but we think, we're heading this way, or that, in 2 weeks' time, the annual validation is due. So we need to make sure that we have got that in the appointment book so that we don't book a whole number of cases on that day because the sterilizer will be, tied up when the technician's here, etc. So to make sure that infection control is one of those things that you keep a watch on, as well as usual things, patient complaints, productivity, where are we with social media, and, where are we with supplies, and the usual things that you would bring up. But that way there's always a button there that people can access to make sure that it's not just forgotten. Because it's a bit of a scary thing when someone comes in to look at a practice from an auditing perspective and they ask one of the dentists, what color is the paint in the sterilizing room? And they don't know because actually I've never been in there, so I wouldn't know. And then it's like, well, these are really important processes that feed into what you're doing in the clinic. And while you don't need to know necessarily every nuance of that, you need to have a familiarization with what those processes are, but you need to understand where all the quality checks are along that pathway, because you're at the receiving end and you are one of the quality checkers at the end. But when you find something that's not quite right, where do you go and what would you do? How would you go backwards and find out if you had a package with a failed indicator or a package where clearly the indicator said that it hadn't been through a cycle? What would you do? The looking backwards and understanding where to go is a really important element.
We've already touched on the fact infection control is quite a moving feast, and there's an apparent increase in technology in our everyday lives. So, Laurie, do you see any AI or new technologies being incorporated into infection control, or any opportunities for this?
I think the answer is different for really large facilities versus small office practices, because if you go into very big facilities, and if you look at the design of many modern large hospitals, they actually already use a large number of robots, and they're actually called cobots, which means collaborative robots. So these actually move around all the large instrument trays. They load them into the washers, they load it in the sterilizers, they move them from A to B, and they work 24/7, and they are actively designed to avoid people. So they're not just robots that are moving around and bang into people. They're actually a bit smart about avoiding the humans in the space. That's why they're called collaborative robots. So spend any time in a big hospital stereo, and it's just amazing what's been done in that space. And that's because of the time it takes to take one item out of an operating theatre and bring it back to use. That can be incredibly long. I'm talking 5-6 hours. So when you've got a list of hip replacement surgeries, or heavens above, if you've got a list of cataract surgeries where you're turning a new patient every 9 minutes, then the instrument volume that you need is a very big issue. Those things aren't immediately scalable down into office-based practice, but some of the lessons from there almost certainly are. And that comes about from just understanding where the weaknesses in a system are. And the more you can remove the human interventions that can go wrong, then the more robust a system that you can build. And a really good analogy to this is if you look at the glass panel cockpit of something like a 787 plane versus the cockpit of, say, a 747-200 from 20 years ago, where there was a flight engineer who looked at 30 gauges and there was about 30 gauges in front of two pilots, and their eyes were scanning all the time to try to look at things. Now with the glass cockpit, you use monitoring, which then brings up and says, oh, you've got a problem in this subsystem. Instead of you having to look and try to be eternally vigilant to spot very subtle changes. So I think there is definitely a place for some of that thinking in terms of error reduction that can come through. We've done some interesting work looking at the performance of cleaning technologies using little tiny tracers, and tracers that can detect very small amounts of bioburden and material. And there are some technologies that can be potentially really useful in that space. And probably one really good example of where a completely automated system might potentially work would be for water lines in dental chairs. So we saw during the pandemic, a lot of people got a lot of stagnation problems in their chairs. They got lots of biofilm, and the performance of different biofilm prevention products and shock treatments varies between chairs, and it varies according to location and water hardness and lots of other factors. But if you've got technology which can monitor the level of organisms in the water in real time, that could then turn up the dosing of a chemical treatment or turn it down. In other words, it could basically look after itself without people having to drop tablets in a couple of times a day. You can actually almost entirely automate that. So we're doing a bit of a proof of concept project on that at the moment, on how that might actually look by having a mini version of a dental chair with all the tubing and then deliberately growing biofilms in there and then monitoring those and looking at how we can clean those out or get rid of them. So those sorts of ideas, I think, would remove the worry. It's, I guess, a parallel to what we already do with an air compressor. You know, we don't race out the back every 5 minutes and turn the air compressor on. Compressor has a switch that when the tank pressure gets below a certain level, the compressor turns on it, and we don't even think about it. It just happens. So we want to do the same sort of thing for as many subsystems as we can, because then we can focus all our attention on the patient who's in front of us, not worrying about all this stuff that's around us to make all that magic work.
Another question we've been asked, Laurie, is whether there's any merit in using alcohol-based hand rubs in lieu of hand washing to reduce aerosols and splatter. Do you have a view on that?
That's a really good question. So the WHO has really pushed the use of alcohol-based hand gels as the universal approach to hand hygiene. And in Australia, the National Hand Hygiene Initiative, which used to be called Hand Hygiene Australia, has also driven exactly the same sort of chapter and verse approach. And this is one reason why in the ADA Guidelines 5th edition, there are some subtle changes in hand hygiene that are actually really convenient changes. So, for example, in the reprocessing area, you wouldn't now have a hand washing sink, you'd just have alcohol-based hand gel. And that's what the staff would use. And that's better for the health of their hands. And it's really only when hands are visibly dirty that you can see contamination that you'd be doing hand washing if you're in the steri room or the reprocessing area. There are some subtle differences about aerosol generation, and when you turn on a tap, you do generate some aerosol depending on the amount of splash. And this is why taps have got aerators on them. So the aerators reduce the amount of splash, particularly when the sink is very shallow or the basin is very shallow. Aerators aren't just there to create this nice fizzing sound that people like. There's actually a functional reason behind them. And it's this recognition that splash can contaminate items. So water from that tap could splash onto items. It can certainly splash onto people's clothes. And when you have wet gowns, then that reduces their protection. So there is a bit of a logic around reducing unnecessary splashing, and getting rid of hand washing and moving to hand hygiene solves that problem. But it's also better for hand health because of the emollients which are found in hand gels, as opposed to just detergents, which you find in liquid hand cleaner. So detergents are actually irritant at microscopic levels, whereas in an alcohol-based hand gel, you can put a whole range of emollients in that reduce irritation to the skin. So that's part of the logic behind it.
Now, that's awesome. It's extraordinary, isn't it? Who would have thought we would have been here 10 years ago? You probably would have, but I certainly wouldn't. Laurie, another question for you now. How important is it, do you think, to separate gowns from regular laundry in our wash? Is it a requirement that we launder them separately, or can it all just go in together?
So I've got a paper coming out next week in the International Dental Journal on some issues around the management of gowns. And in this article, I talk about the laundering of cloth gowns and scrubs versus things that are completely disposable, made out of polypropylene. And there's actually a significantly large base of evidence on cloth gowns, because until fairly recently, many surgical procedures were done with cloth surgical gowns. When you were a dental student, you went to theatre, you probably remember putting on those great big, cotton gowns. The actual science around laundering those is really well known. And people have looked at, well, do you need to put a lot of hypochlorite, or how antimicrobial are just ordinary washing powders and liquids and things like that? And you've probably, if you've ever got a clothes washing powder on your hands by mistake when you're tipping into your washing machine, one of the things that you'll instantly notice is that you lose all the keratin on your fingertips. They instantly become slimy as it proteolyzes all the keratin, and you then lose your fingertip, which is a big problem with your smartphone, because then your thumbprint recognition doesn't work. So what that's showing you is they're very rapidly proteolytic, and that's because they're very alkaline. So when you study the science of what grows in washing machines, you actually find out that they're actually pretty good at decontaminating organisms on an item that you put in. So the science doesn't actually show a relevant difference between doing a separate load or just putting them in with other stuff, because the total reduction of organisms applies to all items that you put into your clothes washer. If you use a dryer, there's another reduction that comes about from things being in the dryer, which is obviously related to the temperature, and things that have got different cotton blends versus cotton and polyester can be dried at different temperatures, as you're probably aware, ironed at different temperatures as well. So when you run a hotter cycle, there's a slightly greater antimicrobial action. But you don't see literature about the carryover of organisms from laundered gowns or scrubs or things like that. There isn't a literature. And the NSMRC guidelines, when they talk about the issue of laundering and gowns and things like that, they actually say this is, there's very, very low level evidence around this recommendation, not this extreme high level randomized controlled stuff. So if you take all that together as a composite, it's at the lower end of importance, because clothes washers work. And in the days before there were disposable diapers and people actually used cloth nappies, as I did for all of my young children, I scrubbed those. You think about this, it's remarkable that you don't see transmission of infection. You have grams and grams of bioburden in front of you. And that's really a testament to how good ordinary laundry products are, because of their aggressiveness and pH at actually killing everyday organisms.
Well, Laurie is a mum with dogs and children. I can tell you right now, there's a lot of biological material that goes through my washing machine. Laurie, there's been a big push in recent times to be considering the environmental impact of dentistry and whether what we're doing by putting so much stuff in landfill is really socially and environmentally appropriate. So a question I've got here is whether there's an environmentally safe alternative to barrier wraps.
Yeah, so I've written a few articles on it, and I'm actually giving a webinar for the FDI in November on the sustainability aspects of infection control. And so there are a couple of really simple things that people used to do that they can go back to doing. So one of those is cloth gowns. And there's a great amount of literature on the environmental impact of that. And if you're using polypropylene, it's one of those so-called, forever chemicals that has a very long life in the environment. And the water repelling abilities and the comfort of cotton and cotton polyester reusable gowns in most studies are actually superior to polypropylene gowns. And the other interesting thing is people feel more protected when they're in cotton and cotton polyester blends than when they're in polypropylene, because the polypropylene sort of floats around you. It's almost like
it's horrible.
It's like, so it doesn't actually do as well. So when you actually compare them head to head, they were really only designed for very high risk scenarios. But then people started wearing them routinely. And in a way, this is where you need to sort of step back and say, well, actually, cloth, when it's laundered properly, and most studies show you can get 80 to 150 cycles from laundering cloth gowns, can be an acceptable option. And the environmental impact is hugely different. It's a change of like 80% difference in environmental impact. There are simple things that people can change and they actually cost no more. And the classic example of that is the large volume suction tip. So many practices use fully disposable 8 or 10 millimeter large volume suction tips, and they throw one away every patient. But you can buy plastic polymer versions of those tips, and you can buy metal versions of those tips. The plastic polymer ones last for about 5 years. The metal ones last forever. You buy it once, that's it. Now, there is a staff effort involved in the laundering of those, but if you've got a washer disinfector, all the common WDs have got a clip-on port where you put the high volume suction tips, and it actually blows the solution detergent up through the middle of them. It's designed for that purpose. So this is a really simple example of where a simple plastic item you can replace with one that is a very long life item, and you immediately get a benefit from that. And there's been some really neat work that's been done overseas in developing reusable washable mask technology. There's a company based in Canada, in Quebec, who've been working on a mask design that you can take and launder and will give you the same level of protection and splash resistance for 100 uses. And they then did it for a respirator as well. And when these sort of technologies are around, there's now a similar type of development that's come out of a company in Israel. There's a lot of active interest in these sorts of smart ideas that can greatly reduce the volume. But if I was to take someone's waste bin and shake it out, the biggest volume component are those polypropylene gowns. So that's why I mentioned gowns first. And then another big component are those big suction tips. So they're the two low-hanging fruit where we know from the science they're a really good solution. So when my article comes out in the first week of November, it'll be open access. People will actually see the breakdown and all the studies on the environmental impacts of those sorts of options. They'll be able to draw their own conclusions from those. But it's an important issue because the large volume fillers, particularly for gowns, is not giving us a net benefit. We're not actually necessarily better off in those polypropylene gowns. We're actually better off in the cotton and cotton polyester gowns.
No, that's fantastic, Laurie. Thank you so much for your time. Really appreciate you taking the time to talk to us and our membership.
Always a pleasure, Annalene. Thank you so much.
Thank you so much to Laurie for that relevant and helpful content. And thank you all for listening. We do hope this podcast was helpful to you, and we look forward to sharing more guidance with you in the future. If you like dental protection podcasts and you'd like to hear more, please subscribe and leave a review.